Preliminary Test 1 for NV2433 Primary Clinical Methods 1. What do we do primary eye examination? An optometrist may first want to look at specific aspects of your visual function and eye health. Preliminary tests can include evaluation of depth perception, color vision, eye muscle movements, peripheral or sight vision, and the way your pupils respond to the light. The aim is to detect any gross anomaly of high refractive error, ocular systemic disease, binocular vision anomaly, and disturbance of ocular motility. And the most of the procedure involve only observation rather than measurement. And the observation will guide the examiner what to look for during the refractive examination and the binocular vision examination. Normally, before we proceed to the comprehensive eye examination, we will do the preliminary test first. Organization of testing procedure of the preliminary eye examination. It should be organized. It must be done quickly, however, without giving the impression of being rushed, and also must inform the patient the purpose of the test so that the whole experience more interesting to the patient. As I mentioned just now, we need to make sure that the preliminary test is organized. So, order of testing, we have vision testing, we have cover test, corneal reflex test, pupillary reflex test, accommodation test, near point convergence, motility test, external observation or slit lamp biomicroscopy, refractive examination, internal examination, tonometry, visual field screening, color vision screening, STREOPSIS test, and also can be include blood pressure tests. The preliminary examination normally begins with the determination of visual acuity. This is a logical starting point, as any complaints of blurred vision elicited during the history can be confirmed, and patients typically expect the doctor or optometrist to have them read the eye chart. Many patients become visible annoyed if they have to seek through a number of the other tests before they are given an opportunity to read the letters on the eye chart. How do you do the measurement of visual acuity? Please refer the previous lecture and previous lab for the visual acuity measurement. What is cover test? An objective dissociation test to elicit the presence of a manifest or latent deviation. It relies on observations of the behavior of the eye whilst fixation is maintained and each eye is covered and uncovered in turn. By means of unilateral cover test, also called the cover-uncover test, the practitioner or optometrist can determine the presence or absence of atropia. By means of the alternating cover test, the practitioner or optometrist can determine whether a phoria or atropia is present but cannot differentiate between the two. Thus, if the unilateral cover test results in a negative finding, a positive finding on the alternating cover test indicates that presence of a phoria. Because the alternating cover test can interfere with the manifestation of atropia, it is customary to perform the unilateral cover test first. Cover test is used to detect strabismus or phoria. It also can detect or determine the laterality, ascertain the direction of the deviation, and also assess the frequency of the deviation. What is the equipment that required for the cover test? There is two things only that require, which is the fixation target and also the occluder. And the fixation target is depend on the visual acuity. For distance, if the patient visual acuity is 6.6, then use target 6.9 for the cover test for distance. And for near, do the test at 40 cm and use the smaller target patient can see. This is example of the opaque occluder that you can use for the cover test. Before you proceed for the cover test, you need to make sure about the position of the patient and also the examiner. Patient need to be seated by their head erect and examiner seated beside, facing and slightly lower than the patient. Make sure that the condition of the room is full illumination, no shadow on the patient face. As I mentioned just now, for the target, for distance, a target at 6 meter and for near at 40 centimeter. As I mentioned before, we have two types of the cover test, which is cover uncover test, or we also can call it as a unilateral cover test. And the second one, which is alternating cover test. Cover uncover test is used to determine the presence or absence of atropia, and the alternating cover test is to determine whether a phoria or atropia is present but cannot differentiate between the two. The procedure for the cover test: first of all, instruct the patient to look at the target, then cover the right eye and observe the left eye. Repeat this step and observe the left eye as the cover is removed. Switch the occluder to the patient's left side and cover the left eye and observe the right eye, and repeat this step. Observe the right eye as the cover is removed. And you can repeat this procedure to confirm the movement of the eye. This is one of the examples of instruction that you can give to your patient. Please look steadily at the letter and ignore what I put in front of your eyes. If the letter appears to move, please follow it with your eyes. Keep your head still and all the times. For the recording, the cover test can be represented in the short form of the CT and record separately for distance, which is represented as D, and for near represented as N. For example, if no movement at near or 40 cm, then you will write down orthophoria at 40 cm. And if no movement at 6 meter or distant, then you write down the orthophoria at 6 meter. If a deviation is detected, then you need to write down the type of deviation, either manifest or latent, the size of the deviation, which is fraction, very slight, slight, moderate, or marked. And if the finding is tropia, you need to write down which eye is a tropia and which eye is fixation eye. And if the finding is phoria, you need to write down also the recovery time, which is slow, fast, or moderate. For the cover test demonstration, please refer to the iFolio. I have uploaded a few videos how to do the cover test on your patient. I have mentioned about the heterophoria before this. It's about a deviate eye, which is a tendency for the eye to deviate from their binocular fixation position when binocular single vision is prevented. What I mean the prevented here is when the eye are dissociated. And dissociation of the eye is usually by occlusion of the eye. Each eye exhibits the same tendency when covered, but magnitude may be vary, it depending on the width viewing distance, either near or distant, from time to time, and also with each eye. For the heterophoria, we have four types of the deviation. The first one is horizontal deviation. Either it can be isophoria, which is cover eye deviate inward, or exophoria, which is cover eye deviate outward. The second one is vertical deviation, either hyperphoria or hypophoria. If the hyperphoria, that means cover eye deviate upward, and hypophoria, cover eye will be deviate downward. We also have a cyclophoria, which is cover eye rotates about a longitudinal axis. It can be encyclophoria or acyclophoria. For the encyclophoria, that means cover eye rotates nasally, and acyclophoria, that means cover eye rotates temporally. And some of the case we have combination, which is combination of the above of the phoria. Heterotropia is different from the heterophoria. Heterotropia means under binocular viewing condition, the visual axis of the eye do not intersect at the object of regard. And one eye fixates the object and another eye is direct as well. It's different from the heterophoria, which is happen when the binocular single vision is prevented. Atropia may not be manifest at all distance. It may revert to aphoria over a range of the distance. So atropia may not be manifest at all time. Sometimes, because of a large aphoria, may become tropia when binocular coordination become decompensated. This will be happen when patient is tired, fatigued, and also illness. And the type of tropia can be unilateral or alternating and can be constant or intermittent. The tropia can be divided into three, which is horizontal deviation, which is either esotropia or exotropia, vertical deviation, either hypertropia or hypotropia, and also the combination of the above. Corneal reflex test or Hirschberg test. We have learned about this test previous lecture. This is an alternative procedure for examining ocular alignment under associated condition. It also to determine the approximate position of the visual axis of the two eyes under binocular condition at near. This test is used to identify a strabismus when other more precise methods cannot be used. This test is rapid, easy to perform, and also require little patient cooperation. For the equipment, we need to have pen light and also occluder. For the setup, the patient need to remove his glasses and the examiner hold the pen light in front of the patient. For the position, the patient is uncorrected and looking at a pen light, and then the examiner stand in front of the patient with one eye closed. The examiner's open eye is positioned just above the pen light. For the condition of the room, it must be moderate illumination. For the procedure, patient is asked to look at the pen light, and then the location of the corneal reflex are noted under monocular viewing condition and also binocular viewing condition. The observation for the Hirschberg test, we will look at the corneal reflex. If the eye straight, so the corneal reflection in the middle or 0.5 mm towards nasal. The placement should be symmetrical due to the visual axis and pupillary axis. If the eye turning, that means corneal reflection temporally. If the eye turn out, the corneal reflection is nasally. And if the eye turn up, that means corneal reflect down. And if the eye turn down, that means corneal reflection is up. For the recording, you need to write down the magnitude, alright, which is 1 mm displacement of the corneal reflex equal to approximately 15 prism or 7 degree of ocular deviation. You also need to write down the direction of the deviation, which eye is deviate, the frequency, and also note down the test that you are using for the test. There is some problem with the corneal reflex test or HIRCHBERG test. First of all, the position of the non-strabismus eye is varies, which is depending on the refractive error. For example, high hyperopia reflect deep more than 0.5 mm in normal, and high myopia reflect deep less than 0.5 mm in normal. In young patients, pen light did not serve stimulation accurately, which is isotropic child accommodate beyond the position of the pen light, therefore cannot detect the tropia. This is an example of the corneal reflex from the HIRCHBERG test. This is what I want you to see when you shine the pen torch in front of your patient. This is another corneal reflex from the HIRCHBERG test. What is your observation? This is the case of the left small exotropia. Test of pupillary function. This test is to assess the afferent and efferent neurological pathway responsible for pupillary function. This test can be direct, consensual, afferent pupillary defect test, and also at near position. So if you do the direct of pupillary function reflex, that means it's a constriction of pupil when the light is shone into the same eyes. For the consensual of pupillary reflex is constriction of the pupil when the light is shone into the contralateral eye. For the afferent of pupillary function defect, it also refers as a Marcus gun pupil. This test, also known as swinging flashlight test, exhibits a paradoxical pupil dilation as the light is moved from the contralateral other eye back to the ipsilateral eye. Positive afferent pupillary defect indicates a lesion in the visual pathway forward to the optic chiasma. For the near reflex test, we determine the pupil either constricted or not when patient is look at the near target. For the test of the pupil function, you need to make sure that the uncorrected patient should steadily fixate at distant target and the examiner should be seated to one side. The condition of the room will be moderate dim room illumination, and please use a bright pen torch as a stimulus. Procedure for the direct test of the pupillary function. From about 5 cm away and from the inferior temporal side, shine the pen torch into the patient's eyes. Observe the amount and speed of constriction of the right pupil. Then please repeat for the left eye. For the procedure consensual test of pupillary function, you need to repeat the procedure used for the direct, but you need to observe the contralateral eye. Procedure for the afferent pupillary defect test for pupillary function. First of all, ask patient fixate at a distant target, and then the examiner shine the pen torch into the right eye and pause 2 to 4 seconds and then move the light rapidly to left eye and pause. The sequence is then repeated. If a paradoxical dilation occurs in the simulated eye, Marcus gun pupil is confirmed and recorded as RAPD. The effect eye must be recorded. For example, RAPD right eye. For the near test of pupillary function, you need to ask patient fixate at distant target steadily and then fixate at near target at 15 cm. The examiner observes the pupil as the patient changes the focus. The pupil should constrict at near target. And you also need to have a look the pupil shape and also pupil size while patient look at the near target. For the recording, if everything is normal, we will write down as a PUPILLARY, which is PUPILLARY means pupil equal, round, reactive to light, and accommodation. If you see any abnormality, separately describe abnormalities such as inequality of size, shape, or rate of response. The grading of rate of response can be 0 until 4. And if pupillary escape is observed on the swinging flashlight test, then you need to record either positive REPD or negative REPD. Interpretation for test of pupillary function. For simple anisocoria, the difference in pupil size more than 0.5 mm, but the difference is the same in both light and dark condition. Referral usually necessary, present in approximately 25% of the population, and should still be noted down on the patient file if let's say that referral is not required. For the anisocoria, measure pupil in dim and bright light, and abnormal pupil will be smaller in dim light or larger in bright light. Refer if cause unknown. It can be caused by the trauma, Horner syndrome, pharmaceutical effect, aditonate pupil, and etc. Interpretation for the afferent pupillary defect. If you see any abnormality from the afferent pupillary defect test, for example, positive RAPD, you need to refer immediately if cause unknown. Interpretation for the light near dissociation, direct and consensual reflex are weak, but the near reflex is strong. Normally, it's because of the neurosyphilis, diabetic neuropathy, pituitary tumor, or cranial nerve 3 damage. You need to refer immediately for ocular health assessment. For the demonstration test of the pupil function, please refer to the iFolio. I have uploaded the video how to do the test of pupillary function. This is an example of the pupillary anomalies, which is aditonic pupil, amerotic pupil, Marcus-Gunn pupil, Horner syndrome, Hutchinson pupil, light near dissociation, Agri-2-Robertson pupil, and also aberrant regeneration of nerve 3. Please go and read more details about the pupillary anomalies from the textbook. Accommodation test. In the accommodation test, you need to understand a few terms, which is accommodation, amplitude of accommodation, and near point of accommodation. Accommodation is referred to the change in the dioptric power of the crystalline lens, allowing focal point change. And amplitude of accommodation is the amount of accommodation as measured from the far point to the near point with max accession. And the near point accommodation is the closest point from the eye at which an object can be clearly seen. This is what happens to the structure of the eye when the focal length is changed, which is if the eye is looking at the distant focus, then the maxillary muscle will be contracted, and then if the eye is looking at the close focus, then the ciliary muscle will be relaxed. This is to make sure that the image on the retina can be seen clearly by the eye. And this process is called as the accommodation. Accommodation test is the procedure to measure in diopters a patient's ability to change the focus of the eye's crystalline lens in response to the annual stimulus. We will use the rough rule to measure the accommodation, and we need to make sure that patient is seated with their head erect and the examiner is seated in front and facing the patient. For the room, the full room illumination but not too bright that can cause pupil to constrict and also unnecessary with no shadow on the patient face. A target or rough rule is held by the examiner at about 40 to 50 cm from the patient eye. The procedure of the accommodation test: direct the patient to look at the target N5 on the rough rule and then occlude left eye. Instruct the patient to keep the letters clear. Slowly move the chart closer to the patient and ask the patient to report when the letters become and remain blurry. Measure the distance from the chart to the patient's spectacle plane in centimeters. Then the linear measurement is referred to as the near point of accommodation, which is NPA. Convert the linear distance into diopters by dividing the near point of accommodation in centimeters into 100. The resulting dioptric value represents the patient's amplitude of accommodation. Repeat with the left eye and also the both eye. And then record the finding. An alternative method of measurement is to start with the letters close to the patient and move them away until the patient reports that the letters are clear. This method is helpful when testing young children who may not understand the concept of blur. This is an example how do you put the rough rule in front of your patients. This is a recording for the accommodation test, which is we will record the amplitude of the accommodation, and each eye you need to measure 3 times of the accommodation. You also can record the accommodation test by writing the near point of accommodation. If you use the near point of accommodation, make sure that the unit is in centimeter. For the demonstration of the accommodation test, please refer the iFolio. I have uploaded the video how to do the accommodation test. Near point of convergence, or we can call it as an NPC. This test is to determine the patient's ability to converge the eyes while maintaining fusion. The same goes with the amplitude of accommodation. We use also rough rule to measure the near point of convergence, and about the position and also the condition of the room is the same like accommodation test, which is patient is seated with their head erect and the examiner is seated in front and facing the patient. Full room illumination with no shadow on the patient face, and a target rough rule is held by the examiner at about 40 to 50 cm from the patient. So the near point of convergence, the procedure will be target of the rough rule, which is target line or dot, is slowly brought inward towards patient nose. Ask the patient to report when the line break into two or become double, or one eye deviate out or one eye deviate in. Ask the patient to report when start to scene one again. And the test need to be repeated by 3 times. Make sure that the finding is consistent. This is the way how do you use the rough rule to test the NPC. It same goes with the accommodation. So the finding for the NPC: subjective, patient is reported diplopia, or objective NPC will be clinician or optometry will observe point when one eye is turned out. How to record the NPC? which is, for example, 8 centimeter filled with diplopia. If let's say that your patient report diplopia, or 5 centimeter with right eye turning in. So that means the right eye is turned in at the 5 centimeter. So interpretation, normal convergent value is between 5 to 8 centimeter. If the MPC is 12 to 15 centimeter, suspected deficiency of convergence. So NPC demonstration, please refer to the iFolio. I have uploaded the video for the near point of convergent demonstration. Ocular motility test, we use the Broad-H test, which is to assess the patient's ability to perform conjugate eye movement or to evaluate extraocular muscle function. In this test, we need the pen light as a for equipment, and you need to know which muscle you are tested, and for this you need to refer back your previous lecture for the anatomy ocular. For the ocular motility test, position of the patient is seated with their head erect, and the examiner is seated in front and facing the patient. The patient removes his spectacle, and the examiner will hold the pen light. The condition of the room is full room illumination with no shadow on the patient face, and the target is held by the examiner at about 40 to 50 centimeters from the patient. For the procedure, move the target horizontally to the left and to the right to evaluate the medial and lateral rectus. With the eye turned about 15 degrees, reflect deplace 1 mm. Move the pen up and down along the vertical line and evaluate the superior and inferior rectus. With the eye turned 45 degrees, move the target up and down along the vertical line to evaluate the inferior and superior oblique. Example of the instruction that you can use. Please watch this target. Keep your eye head still and only move your eye to follow the target as I move it in front of you. If any reason you find that you cannot keep looking at the target, please tell me. For recording, if the patient follows the light smoothly to all positions of gaze with both eyes and never reports diplopia or double vision or discomfort, write SAFE, S-A-F-E. This letter stands for S smooth, A accurate, F full, E extensive. If the patient shows any problems, record only the letter that apply and describe the problem. Either jerky, unsteady, nystagmus, fail to follow location, restricted, or lagging. Identify also the direction of gaze that result of diplopia and or discomfort. If one eye is the abnormal, be sure to identify it. Example of the recording, AOM safe, AOM diplopia on upright gaze, right eye lagging. For demonstration ocular motility test, I have uploaded the video. Please refer to the iFolio. STREOPSIS test is to measure a patient's fine depth perception through his ability to fuse stereoscopic target. So the equipment for this test is either you can use the stereo test book with Polaroid glasses, which is you can use stigmas fly or render, or you can use the TNO stereo test with the red and green glasses. This is an example of the stereo booklet, and the first one will be the thickness, and also the second one will be render test. Both of these tests need to use Polaroid, and then the third one will be TNO test, and you need to use with the red and green glasses. Position of the patient. Patient is seated and patient hold the test book and wearing Polaroid glasses or red-green glasses over his near correction. Okay, and the examiner is seated in front and facing the patient. The condition of the room, full room illumination with no shadow on the patient face. test book is held by the patient at about 33 to 40 centimeters from the patient. The procedure is patient is direct to report the object that stand out from the book, and please refer the manual for each stereo booklet. For the recording, for the normal value is 40 seconds of arc or better. For example, recording is 40 seconds of arc and you need to write down what test you are using. For demonstration for the STREOPSIS test, please refer to the manual of each booklet. And for the practical, please refer to the lab manual, and also you can refer to the textbook Carlson and also Grossman. Thank you.